Welcome to this postoperative management review, brought to you by Roadmap to Residency. Postoperative questions are some of the most predictable points on the entire exam because the patterns repeat over and over. A patient is a day or two out from surgery, and something goes wrong. They have pain, they are nauseated, they cannot urinate, or they spike a fever. Your job is to recognize the pattern instantly and pick the next best step. Today, we are not going to reteach all of surgery. We are going to show you exactly how these question stems are built and how to attack them so you can score easy points. Make sure you are also drilling these topics in your question bank and reading a trusted surgery review resource alongside this video because these patterns stick best when you practice them. Let us get started. Here is what we are going to cover today. First, you will learn to recognize the 4 classic postoperative complications the instant they show up in a question stem, because the test writers describe them in very predictable ways. Those 4 are pain that is not well controlled, nausea and vomiting after anesthesia, the patient who cannot urinate, and the patient who spikes a fever. For fever, we will use the famous 5W framework, which sorts the causes by how many days out from surgery the patient is. Throughout the video, we will walk through board-style practice questions together and break down why every single answer choice is correct or incorrect. This is the skill that earns points. We assume you already have baseline knowledge from your review resources, so our job is to sharpen how you attack the questions. Our first topic is postoperative pain control, and the strategy here is to match the drug to the severity of the pain. When the stem describes mild pain after a minor procedure, the right answer is usually acetaminophen or a non-steroidal anti-inflammatory drug. When it describes severe pain right after major surgery, the right answer is an opioid, very often delivered through a patient-controlled analgesia pump that lets the patient press a button for relief. A classic trap is offering a weak oral pill to a patient who is clearly in severe pain, so do not undertreat. Now here is the part the test loves to hide. The dangerous complication of pain control is giving too much opioid. So scan every pain question for the respiratory rate. If you see a slow respiratory rate, a very sleepy patient, or pinpoint pupils after pain medicine, that is opioid oversedation, and the answer is to support the patient's breathing and give the reversal agent naloxone. Spotting that respiratory rate is worth easy points. Now we cover 2 more complications together because the test asks about them in the same predictable way. First is nausea and vomiting after anesthesia. This is extremely common, and the classic setup is a young, female, non-smoking patient who is queasy and vomiting in the recovery area. The first-line drug to know cold is Ondansetron, a serotonin-blocking agent. Before automatically medicating, the best answer also looks for a fixable cause, such as too much opioid, low blood pressure, or a stomach that needs a tube to decompress. Second is the patient who cannot urinate. Picture someone several hours out from surgery, uncomfortable, with a fullness you can feel low in the belly. That is urinary retention, and opioids and spinal anesthesia are the usual triggers. The winning sequence is scan and then drain. Get a bladder scan to confirm the bladder is full, then place a catheter to empty it. Do not get distracted by answer choices about dialysis or kidney imaging. Confirm the full bladder, then relieve it. Now the highest yield postoperative topic of all, fever, and the famous 5W framework. The single most important clue is how many days out from surgery the patient is, because the timing points you to the cause. Here is the order, and they all start with the letter W. Wind is first, on the night of surgery through the first day, and it means the lungs, usually collapsed air sacs called atelectasis. The fix is deep breathing and walking. Water is next, around days 3 through 5, and it means a urinary tract infection, often from a catheter. Walking comes around days 4 through 6, and it means a clot in the leg veins that can travel to the lungs. Wound is days 5 through 7, an infected incision that is red, warm, and draining. And wonder drugs is any time, covering drug fever and any line or catheter that has become infected. Here is why this matters for test taking. The timing lets you eliminate wrong answers quickly. A fever on day 1 is almost never a wound infection or a leg clot because it is simply too early, so cross those off. A red draining incision on day 6 is a wound infection. Let the day number narrow the field before you choose, and the answer often falls right into your lap. Let us work through our first practice question, and this one tests pain control. A 60-year-old man is recovering on the surgical floor several hours after a major open abdominal operation. He reports severe pain, a 10 out of 10, right at his incision. Here is the key detail to notice. He is fully awake, his breathing is comfortable at 16 breaths per minute, and his blood pressure and oxygen level are all normal. So far, he has only received acetaminophen. The question asks for the most appropriate next step. Before you choose, scan the vitals, because the test often hides an over-sedation trap in pain questions. But watch what these numbers are actually telling you here. Read the 4 options, pick your answer, and we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. We have severe pain right after major abdominal surgery in a patient who is wide awake, breathing comfortably, with normal vital signs. The acetaminophen he has gotten is simply not enough. And because his breathing and alertness are perfectly normal, there is no over-sedation here. This is undertreated surgical pain. Second, apply the rule, which is to match the drug to the severity. Severe pain after major surgery deserves an opioid, and the patient-controlled analgesia pump is the ideal delivery because the patient can press a button to titrate relief to their own need. That makes the answer choice letter B. Third, eliminate the wrong answers. Choice letter A continues a weak medicine for clearly severe pain, and that timid choice is the classic trap. Choice letter C is naloxone, the reversal agent, which is only correct when there is opioid over-sedation with slow breathing. His breathing is normal and he has not even received an opioid, so this is wrong. Choice letter D orders an emergency scan to hunt for a complication, but nothing in the stem suggests one, and it does nothing to treat his pain. The correct answer is the patient-controlled analgesia pump. The lesson is to always read the respiratory rate because it tells you whether to escalate the opioid or reverse it. Here is our second practice question, and this one is about nausea and vomiting after anesthesia. A 28-year-old woman who has never smoked is in the recovery area after knee surgery under general anesthesia. She feels very nauseated and has vomited once. Notice the reassuring details. Her blood pressure, heart rate, and oxygen are all normal. Her breathing is comfortable and her abdomen is soft and not swollen. She did receive a standard dose of opioid during the case. The question asks for the most appropriate next step. The key is to recognize the classic profile of nausea after anesthesia, a young, female, non-smoking patient, and to notice there is nothing in the stem pointing to a surgical emergency. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, rule out a surgical cause. The stem deliberately tells you the vital signs are normal and the abdomen is soft and not swollen. That is your reassurance that this is not a bowel obstruction or internal bleeding. The cause of her nausea is obvious, the general anesthesia and the opioid she received, so this is ordinary nausea and vomiting after surgery. Now, why does first-line medicine win? Ondansetron, a serotonin-blocking agent, is the standard first treatment for nausea after anesthesia, so choice letter A is correct. Let us clear the others. Choice letter B, a tube through the nose to decompress the stomach, is the treatment for a bowel obstruction, but her soft, flat abdomen argues strongly against that. Choice letter C, an urgent scan, and choice letter D, returning to the operating room, both chase a surgical emergency that the normal vitals and soft abdomen have already excluded. They are overkill traps. The correct answer is Ondansetron. Now, a quick combined question and answer on urinary retention, so you can see the whole pattern at once. A 70-year-old man has not passed urine for 8 hours after a hernia repair done under spinal anesthesia. He feels a strong urge and discomfort low in the belly, and when you examine him, you feel a firm, rounded fullness right above the pubic bone. His vital signs are normal. The choices are: letter A, place a urinary catheter to drain the bladder; letter B, start dialysis; letter C, order a scan of the kidneys; or letter D, give a large bag of fluid into the vein. Take a moment to choose. Here is the reasoning. This is textbook urinary retention, and spinal anesthesia is a classic trigger. The firm fullness you can feel is the distended bladder, which confirms the diagnosis. The right next step is letter A, place a catheter and drain the bladder. In practice, a quick bladder scan confirms it first, but draining is the relief the patient needs, and it is the best option offered. Let us eliminate the rest. Dialysis treats kidney failure, which this patient does not have. A kidney scan looks in the wrong place because the problem is the outlet, not the kidneys. And giving more fluid into the vein only fills an already overfull bladder and makes things worse. The answer is the catheter. Remember the sequence: scan and then drain. Here is our fever question, and it is a perfect test of the 5W framework. A 65-year-old man has a temperature of 38 degrees on the very night of a long open abdominal operation. Notice the timing because it is the most important clue. He is taking shallow breaths because his incision hurts, and he refuses to breathe deeply. On exam, his breath sounds are decreased at both lung bases. Now notice what is reassuring. He has no cough. His incision looks clean and dry. His legs are not swollen, and his urinary catheter is draining clear urine. The question asks for the most likely cause of his fever. The choices are: letter A, collapsed air sacs in the lungs called atelectasis; letter B, a wound infection; letter C, a clot in the deep veins of the leg; or letter D, a urinary tract infection from the catheter. Let the day number guide you. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, why is it the lungs? The fever is on the very first night after surgery, and that is the wind stage of the 5W framework, which points straight to the lungs. The patient is breathing shallowly because his incision hurts and his breath sounds are decreased at both bases. That is the textbook picture of collapsed air sacs, called atelectasis. So choice letter A is correct. The treatment is simple and worth knowing. Get him to breathe deeply with an incentive breathing device, control his pain so he can take full breaths, and get him walking. Now let the timing eliminate the rest. A wound infection, choice letter B, and a leg clot, choice letter C, both take several days to develop, so on the first night they are simply too early, and the clean dry incision and the normal legs confirm that. A urinary tract infection, choice letter D, is always on the differential when there is a catheter, but his urine is clear and his lung exam clearly points elsewhere. This is the power of the framework. The day number lets you cross off wrong answers fast. The correct answer is atelectasis. Here is a pearl that ties this whole video together, and it is the single most powerful move for postoperative questions. Anchor on the day number. Whenever a STEM tells you how many days out from surgery the patient is, treat that number as a flashing clue. Before you even read the answer choices, ask yourself which complication fits that timing. For fever, day 1 is the lungs, days 3 through 5 is the urinary tract, days 4 through 6 is a clot in the leg, days 5 through 7 is the wound, and any time points to drugs or an infected line. Sorting by timing instantly shrinks 4 answer choices down to 1 or 2, and that is where easy points come from. Then comes the second half of the pearl. Treat the cause, not the number. Once timing points you to the underlying problem, choose the answer that fixes that problem with the simplest effective step, rather than the answer that just lowers a number on the monitor. For early lung collapse, that means deep breathing and walking, not just a fever reducer. For the patient who cannot urinate, that means draining the bladder, not pouring in more fluid. Find the timing first, then treat the cause. Do that, and these questions become some of the most reliable points on your exam. That wraps up our review of postoperative management. Let us lock in the core ideas. For pain, match the drug to the severity and always read the respiratory rate to catch opioid oversedation. For nausea after anesthesia, reach for Ondansetron and look for a fixable cause. For the patient who cannot urinate, scan the bladder and then drain it with a catheter. And for fever, let the day number guide you through the 5W framework: wind, water, walking, wound, and wonder drugs. The single most powerful habit is to anchor on the postoperative day number and treat the underlying cause with the simplest effective step. The best way to make all of this automatic is to drill these exact topics in your question bank and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.